Hi everybody, my name is Tom Fusillo. I'm a second-year internal medicine resident, and I made this video today to talk a little bit about diffuse large B-cell lymphoma. I think it's a pretty interesting topic, and even though not every physician is going to be treating diffuse large B-cell lymphoma, a lot of us will have patients who have had or have it. So I think it's good to kind of have a little bit of an understanding about the disease process. I'd say this is probably medical student to residency level stuff here. So with that, I hope you find this helpful.
So without further ado, let's get started on this lecture on diffuse large B-cell lymphoma. So starting out with some epidemiology here, the first thing to note is DLBCL, most common type of non-Hodgkin lymphoma. So we see all the lymphomas here, Hodgkin's, non-Hodgkin, CLL, plasma, dyscrasias. The vast majority are non-Hodgkin's. And when we look at the breakdown of the non-Hodgkin's, DLBCL is the biggest, the most common here, about 31%, and then the rest are subtypes. Now, the 31% here also includes all the subtypes of DLBCL, which there are plenty. Important to know, median age of diagnosis, mid-60s. About 1/3 of patients are diagnosed when they're over the age of 70. Immunocompromised states are risk factors, so these include things like HIV, autoimmune conditions, organ transplants, and hepatitis B, C, Epstein-Barr, you'll see a lot in lymphomas, as well as HHV-8, also risk factors. Pesticides and ionizing radiation also have been shown to increase risk of DLBCL and some non-Hodgkin's lymphomas. And finally, interestingly, studies show that alcohol exposure, prior transfusions, and sun exposure could be partially protective. Take that with a grain of salt, but I find it a little bit interesting. You have to learn a little bit about the molecular biology and the genetics when it comes to any lymphoma, but especially DLBCL. And the main reason is because it really impacts prognosis and a little bit of management. And so when we look at the molecular biology and the genetics, there's three main proteins and genes to know about. Two of them are in this image here. Two here are the MYC gene, transcription factor, and BCL2. So looking at these two, let's start with BCL2. So BCL2 is an anti-apoptotic protein that's enhanced in DLBCL. So the theory is that the BCL2 overexpression will provide a survival advantage for malignant B cells and play a role as well in resistance to chemotherapy. So looking here, everything down here has to do with apoptosis, okay? And then you have these two things, Bax and Bach, two proteins here that start the apoptosis pathway. Now, BCL2 inhibits Bax and Bach. So BCL2 is stopping apoptosis. You can imagine in a mutated cancerous cell, if BCL2 is stopping apoptosis, it's promoting the ongoing life and growth of a cancerous cell. That's not a good thing. So thus, when it's overexpressed, prevents the apoptosis in these malignant cells. Now we look at MYC next. MYC is over here. MYC is pro-apoptotic, right? Because we can see it leads to the enhancement of Bax and Bach, and then we get apoptosis. So MYC is pro-apoptotic. When it starts in this apoptosis pathway, MYC works by causing some DNA damage, which leads to apoptosis. So that's how it works in apoptosis. But you can ask yourself, if MYC is pro-apoptotic, how does that help a cancer cell? Because you'd think, oh, the cancer cell will just die earlier. It'll just go into apoptosis. But MYC also has a secondary role, which is a really crucial player in regulating cell cycle, particularly promoting the cell from G1 to S phase. So when it's overexpressed, you can imagine, accelerates that transition from G1 to S, and these cells can divide much more rapidly. And some research has shown that in the MYC gene, SNPs, or single nucleotide polymorphisms, the number of those you have directly correlate with increased cellular proliferation. The third of these genes is BCL6. BCL6 is a little more interesting, in my opinion, because you can see here on the left, it inhibits both tumor suppressors and oncogenes. So if it inhibits both, how is that going to give a cancerous cell an advantage? So it just so happens that when it's overexpressed, or when it's even relocated or mutated, it loses a lot of its ability to inhibit the oncogenic properties, but it's still inhibiting tumor suppressors. You have this kind of tipping of the scales here, and the oncogenes go off unchecked, and you get this proliferation in the DLBCL. Next is to talk about the subtypes. There's a bunch of subtypes of large B-cell lymphomas. DLBCL has a few specific to it that we'll talk about here. Looking at this, first we have our large B-cell lymphomas, and I've divided this into a few sub-branches for the sake of this video. You have all of these over here, many different types of subclasses of large B-cell lymphomas. These are ones that we're not going to talk about in this video. And then over here, we have two that we will talk about, which is high-grade large B-cell lymphoma and DLBCL of NOS type or not otherwise specified. And within that, within the NOS, we have GCB, which stands for germinal center B-like, and ABC, activated B-cell-like. And there's going to be some within here that are unclassifiable, but that'll still fall under NOS. So these are the ones we'll focus on in this video particularly. The first two to really differentiate between here is GCB and ABC subtypes. As we look here, what characterizes each of these? What are the differences? What are the similarities? Well, like the name is going to say, the GCB type, the cells that you see are going to look and are similar genetically as well to germinal center B cells. The GCB type is more common. It's about 65 to 35%, 65% GCB, 35% ABC, 60-40, around there. It's also important to know the difference because GCB has better outcomes and progression-free survival. Because GCB has better outcomes and progression-free survival. 3-year PFS here is about 75%, so it's a good prognostic indicator. The markers that you see with GCB, CD10 positive. CD10 is only expressed in GCB. BCL6 as well. BCL6 is highly expressed in GCB, but you can see it rarely in ABC as well. And MYC is much more common in GCB as well. Finally, the translocation. So the translocation between chromosome 18 and 14, which is BCL2 and IgH, IgH is immunoglobulin heavy chain, occurs in about 45% of GCBs. It never occurs in ABC. Okay. If you see the rearrangement between BCL2 and IgH, it's going to be a GCB subtype, not ABC. This is also something that's present in follicular lymphoma. You can see in some other lymphomas as well, like Burkitt's. And next, about 90% of high-grade B-cell lymphomas are going to be germinal cell B-type. It's interesting because, like we said earlier, GCB generally has better outcomes, but keep in mind, the exception to that is if you're high-grade, which the majority of high-grade are GCB. So that is the exception to this better outcome rule here. So let's look over now at ABC subtypes. These cells are post-germinal center B cells. They have worse outcomes. The 3-year PFS here is closer to 40 to 50%. A lot of its survival is based on the activation of NF-kappa beta. And when we look at the molecular and the genetic side of things, MUM1 is overexpressed in only ABC. So if you see MUM1 positive on your stains, this is going to be an ABC type. Okay. BCL2 is expressed in both subtypes, but it's predominantly expressed in ABC. The exception, like we said, is if there's actually a BCL2 rearrangement, then we're looking at GCB. So overexpression, ABC, but if it's a rearrangement in the 14-18 rearrangement, it's going to be GCB. And MYC is also expressed in ABC occasionally. Another thing to mention when it comes to MUM1 here, MUM1 is also referred to as IRF4. It's overexpressed only in ABC, but I don't want you to confuse this with a different subtype of large B-cell lymphoma, which is called large B-cell lymphoma with IRF4 rearrangement. That refers to a large B-cell lymphoma where the MUM1 or the IRF4 is actually rearranged, whereas here we're talking about an overexpression, because you could have two different things. One can be rearranged on the actual gene or chromosome versus having an intact gene that's not rearranged, but the cell is just expressing a bunch of the protein, transcription factor, whatever it is. ABC has the majority of double expressor types. That's a difference between double expressor and high grade, which is sometimes referred to as double hit, which we'll get to in a bit, but just remember double expressor, more likely to be ABC. And so after we know all this, how can we actually distinguish between the two when we have done our workup? There's this thing called the Hans algorithm that you'll see down here, which is a pathological algorithm for understanding how to differentiate between these two. The first thing is, if you have CD10, if your tumor cells are CD10 positive, automatically GCB, right? CD10 is a marker of germinal center B cells. So if it's positive, you have to have a GCB type. If it's negative, then you have to go through a few more steps. CD10 negative and then BCL6 negative, you have ABC, a non-germinal center case. It's an ABC type. If your BCL6 is positive, then we look at MUM1, right? Because MUM1 only expressed in ABC. So if you have MUM1, then it's going to be ABC. If you don't have MUM1, and these are in the patients with BCL6, it's not going to be ABC, it's going to be GCB. Remember, these are expressions, not necessarily referring to rearrangement. This is referring to expression. You'll see this on your immunohistochemistry. So the genes, like we said, they seem to be correlated with different types, whether it's ABC or GCB. What we're looking at here on the left is if you look at all the patients with each type of expression, BCL2 is expressed, MYC is expressed, both are overexpressed. Most of these are predominantly in ABC. So you see ABC is this gray, each of them over 50%. Roughly, MYC is the closest to half and half, but all of them are over 50% overexpressed in ABC. That's probably causally aligned to why ABC has a worse prognosis than GCB. So we look over here at MYC and BCL2 overexpression called double expressor. About 66% of these double expressor cases are in the ABC type, which also would contribute to worse prognosis. And then over here, we look at delineating by type, and we're looking at double expression here, not double hit. Double expression meaning they're both overexpressed, but not rearranged. And we see that about 46% of ABC have double expression, so another negative prognostic marker. Whereas on the other hand, GCB, it's much less common to have these double expression in GCB. Only about 22% of GCB have double expression. Again, it's interesting here because vast majority of double hit are GCB, but the vast majority of double expressor are ABC. And again, why do we care about GCB versus ABC? Like we had mentioned, ABC has a significantly worse prognosis, significantly worse overall and progression-free survival. So we see on the left, we see the PFS where ABC is well below the line of GCB PFS, and then similar with overall survival, ABC well below the GCB line. Okay, so let's talk a little bit more about MYC and BCL2/6, and more specifically, the differences between double hit and double expressor. You can also have triple hit, which I put in parentheses there. But let's start talking about by double hit here. So this is referring to gene rearrangements. The difference between hit and expressor, when we talk about is hit refers to the genes are actually rearranged, and double expressor or expressor type just means that these proteins, these transcription factors are overexpressed. The gene itself is intact, but they're overexpressing their proteins. So there it is, overexpressing of the proteins. We look at double expressor, there's no underlying chromosomal rearrangements. And on the other side, so what does double, triple hit mean? MYC, if you have a MYC rearrangement and one of the BCL rearrangements, you have double hit. Okay, so for example, MYC is rearranged and BCL2 is rearranged, you have double hit. MYC is rearranged and BCL6 is rearranged, you have double hit. And then if you have all three, MYC, BCL2, BCL6, you have triple hit. Again, this is important because these people are going to have worse prognosis, a worse outcome. The double and triple hit counts for about 5 to 7% of your DLBCL cases. And again, like we said earlier, over 90% of these are of the GCV subtype. Double expressor, on the other hand, is not a distinct entity, but it is nevertheless a prognostic marker. And double expressor, we're referring to MYC and BCL2. So BCL6 doesn't really have a role in double expressor type, referring to the overexpression of both MYC and BCL2. And then double expressor we see is about 20 to 30% of DLBCL cases. We really only look at BCL2 in double expressor. You might be asking, why don't we care about BCL6? It's because BCL6 is almost exclusive to germinal cell types. You really won't see that here. So MYC and BCL2 are overexpressed. You have double expressor, diffuse large B-cell. So if MYC and BCL2 are overexpressed, you have double expressor diffuse large B-cell lymphoma. So this is a bit of a busy slide, but what we're showing here is expressor, overexpression of MYC and BCL2. And so we look at all these patients, you see those who are MYC and BCL2 overexpressing much lower overall survivorship as compared to all other patients. Okay. Same thing goes with progression-free survival here. If you're double expressor, much worse than all other expressor categories. So now we look over here. What this is referring to is those on the bottom line are both MYC and BCL2 overexpressing, whereas the top line are just BCL2 overexpressing. So they're MYC negative, meaning their MYC is not overexpressed, but their BCL2 is. Now, if you look, we're not going to go too deep into the rest of these, but the whole point of the other 4 graphs here is we're looking at the overall survival of patients who are expressing either MYC or BCL2 as compared to those who express both. And in any way you splice it, if you express just one as compared to overexpressing both, the prognosis is significantly better as to if you overexpress both BCL2 and MYC. So just to be totally clear about this, if you are overexpressing MYC but not overexpressing BCL2, you're better off. If you are overexpressing BCL2 but you're not overexpressing MYC, you're better off. So main takeaway here is overexpressing just one of these is not a significant prognostic indicator. So we'll talk about CNS DLBCL a little bit here. This refers to a recurrence or progression of disease into the CNS. So this occurs generally pretty quickly after first-line therapy. This is the most common time that you really see it, which the theory behind this is, in many cases, the DLBCL probably was smoldering somehow in the CNS from the beginning, because otherwise, why would it pop out right after first-line treatment? And that'd be pretty quick for recurrence or progression, de novo in a sense. CNS DLBCL, we see about 3 to 5% of patients as a median overall survival of less than 6 months. So as you could imagine, really terrible prognosis, a terrible diagnosis to have. An MRI brain and spine with contrast is needed for full evaluation. Interestingly, in known CNS involvement, testicular ultrasound is recommended. The reason for this is we've looked at data, patients who have had DLBCL with the lymphoma in the testes, much higher chance of having it spread into the CNS. There's a few other organs that's commonly considered to be associated with. The kidneys is one, breast has been another. Some of these have been disproven, some hold up. So it's always important to think of, depending where the lymphoma is, do we need to look harder to see if there's CNS lymphoma and vice versa. A lumbar puncture with CSF cytology and flow cytometry is really crucial in this case. The LP is, of course, recommended only if there's no neuroradiological contraindication. If somebody's having high pressure or there's some sort of sign of early mass effect, something like that, you might want to avoid and consider deferring that to a later time. An ophthalmology exam is recommended here to see if this involves the back of the eye, vitreoretinal involvement. And a confirmatory brain biopsy is helpful, but not 100% necessary. You can make it on just radiology, although it's not as easy and not as straightforward. And importantly, this is a really important point, is to avoid steroids until the workup is complete. Steroids can alter the contrast enhancement. It shrinks tumors in general, but it can really alter the contrast enhancement, which could make your MRI look non-diagnostic. Imaging with gadolinium enhancing lesions. And then when we look at the imaging on the right here, we see a brain MRI with contrast. And what's pretty typical is you see this gadolinium enhancing lesion here. And characteristically in CNS DLBCL, it crosses the midline. So it crosses the corpus callosum here. More commonly interesting as well, it's intraparenchymal rather than outside and leptomeningeal. Going on with CNS DLBCL, like we said, it usually occurs shortly after completing the first-line therapy. Higher risk with the ABC subtype, double expressor, and testicular involvement. And there's something called the CNS IPI, or the International Prognostic Index, which can be used to predict risk of developing CNS disease. Down here is what we look at, and it's these components, risk factors like extranodal, LDH, age. So you get a point for each of these, and then it stratifies you into what your risk is for developing CNS DLBCL. And over here is just showing all of these, with the exception of extranodal involvement over 1, are independently associated with higher risk of developing CNS disease as well. So why do we care about this? Some clinicians might choose to give a systemic prophylaxis in high-risk cases. If you have a patient who's maybe younger, they're at higher risk of developing CNS disease at some point in their course, it might be worthwhile to think about giving them a prophylactic agent. Importantly, though, intrathecal prophylaxis is not recommended. It's been looked at, hasn't really improved outcomes, of course, has a bunch of toxicities associated with it. We'll talk a little bit more about prophylaxis when we get to treatment. So the workup and the pathology, how do we go about this with DLBCL? Diagnostic workup, there's a few main portions of it. So you have your IHC, your immunohistochemistry, and that's going to stain for a bunch of different agents, maybe not all of these, maybe some of these. It's different case to case, right? Every patient's going to be a little different. For your flow cytometry, FISH or fluorescent in situ hybridization, it's going to be helpful in looking for your rearrangements. And then, of course, the histology. What does this look like under the microscope? Can we diagnose DLBCL? So we'll start with histology. I'm by no means a pathologist. Many of you probably are not. But the way I always think about this as well, it's in the name, what it looks like on histo, on H&E, which is you have diffuse large B cells. So you basically have these sheets of large B cells. You see these hyperchromatic nuclei. It's just packed in here with B cells. There's not much else in here besides these big lymphocytic looking cells. This one was read as DLBCL NOS. The official read is effacement of normal tissue architecture by a diffuse infiltrate of large atypical lymphoid cells. And same here, a little higher power. You can see these as very big lymphocyte looking cells with these dark nuclei. Again, read as DLBCL NOS, large atypical lymphoid cells with pleomorphic nuclei, prominent nucleoli, and vesicular chromatin. Looking at the IHC or the immunohistochemistry, this is what this would generally look like for each stain. You do so here, we're seeing CD20 positive. You see all the brown staining on the outside, the periphery of the cell. CD20 marker of B cells. CD10 positive here with these brown on the outside of the cells. CD10, remember, as we said, a marker of germinal center B cells. So if you have CD10 positive like you do here, this would be a GCB subtype. And then remember, IHC, we're looking at expression, not rearrangement. So we're seeing BCL2 and MYC are both expressed here. So putting this together, if you were to have a patient and you see these stains and you know they have DLBCL, what would be the diagnosis? Think about that for a second. You know it's B cells. You know it's a germinal center type because you have CD10 and it's double expressors. So you'd have a germinal center GCB type double expressor diffuse large B-cell lymphoma. Now look at the FISH, fluorescent in situ hybridization. I think is always pretty cool and interesting. So this specific image is looking at the MYC and BCL2 rearrangement. The way this works, look at the top one here with MYC. We have these two fluorescent markers that stain each end of the MYC gene. The red is staining the 5' end, the green is staining the 3' end. So if they're staining the two ends of the same gene, then you'd think that they should be pretty close together. You should see the red and the green pretty close together, right? Because they're on the same gene. Nevertheless, we see them close together here, but totally split apart over here. Seeing them split like this, we know that the gene is rearranged. Same thing down here with BCL2. The 3' end of the BCL2 gene is stained green. The 5' end of the gene is stained red. Here we see them on top of each other, which is how they should look, but then they're split apart, indicating some sort of rearrangement here. So looking a little more at FISH, BCL2, let's start on the left here. So how do we read this? Remember, rearrangements, the different color probes, should be contiguous, meaning they're on top of each other. If they're split, you know that there's been a rearrangement. If we're looking for a translocation, the different color probes would be split, not on top of each other. And I'll show you that when we get to MYC here, because this is a translocation. So let's start here, BCL2, right? So remember, the way our probe works here is we're staining the 5' and the 3' end. And in each cell, most of them have at least one where they're on top of each other, but they all have red and green split apart, indicating some sort of rearrangement. Same here with the MYC. Here, they're on top of each other, but then we see them split over here, split. BCL6, same thing here. Split up on top of each other, but split. And so over here, what we're looking for is a MYC-IGH translocation. IGH is on chromosome 14, MYC is on chromosome 8, so this would be looking for 8-14 translocation, which you can see in DLBCL. It's more common in Burkitt's. And so the way the probes here work is the red is going to stain for MYC, and the green is going to stain for IGH, or the immunoglobulin heavy chain. And because these are on different chromosomes, you'd expect them to be separated when you stain here. So if you see them on top of each other, that means there's been a translocation. So here we see they're on top of each other, on top of each other, on top of each other. There's been a translocation here. And so up here, just to solidify concepts we've been talking about, double hit if you have BCL2 and MYC rearrangements, or MYC and BCL6, you would have double hit in either of these cases. And then triple hit, if you have all three arrangements, you'd have triple hit.
So I hope that was a helpful kind of intro to DLBCL, talking about the workup, the pathology of it all. And if you want to know more, check out the next video, which is on treatment of DLBCL. And I hope that you'll enjoy that as well.